This video series will demonstrate the complete assessment and classification process for a child aged 2 months up to 5 years, and then for a young infant. The video is designed for use in conjunction with the case management training modules and the chart booklet. Before commencing with the assessment of individual outpatients, it is important for the health worker to identify those children who may require urgent medical attention and to attend to those patients immediately. During the assessment, the health worker must establish good communication with the mother.
First, the health worker welcomes the mother and asks the child's name and age. She asks the mother what the child's problems are. She also asks if this is the first visit for these problems or a follow-up visit. She speaks to the mother using words that the mother will understand and ensures that the mother understands the questions being asked. The health worker praises the mother for bringing the child to the clinic. The health worker is then ready to begin the assessment. First, she checks for general danger signs.
A general danger sign means that a child has a serious condition. This condition may require immediate life-saving attention, such as antibiotics by injection, oxygen or other medicines, which may not be available at the clinic. Therefore, a child with a general danger sign may need to be referred to a hospital. To check for a general danger sign, ask the following.
Is the child able to drink or breastfeed? A child is not able to drink or breastfeed if the child is not able to drink at all. This child is able to drink. A child not able to drink or breastfeed includes the child who is too weak to suckle or swallow. This child is not able to drink.
A breastfeeding child may have difficulty suckling when his nose is blocked. However, when the nose is cleared, the child can continue breastfeeding without difficulty. This child does not have a general danger sign.
Does the child vomit everything? If the child tries to drink but vomits repeatedly and is unable to keep anything down, the danger sign is present.
Has the child had convulsions during this illness? A child with convulsions during this illness may not be convulsing when you see the child. Ask the mother if the child has had convulsions during this illness. Use words and gestures she will understand. The mother may describe convulsions using words such as fits or spasms. If a mother reports convulsions during this illness, the general danger sign is present.
Next, the health worker looks to see if the child is lethargic or unconscious. A lethargic child is drowsy at all times, even when the child should be awake and alert. The lethargic child does not look at the mother or watch your face when you talk.
The child may fail to waken when the mother talks or when you clap your hands. Even a very young baby who sleeps a lot should respond to these sounds. If the child does not respond to clapping, shake the child gently.
An unconscious child cannot be wakened. She does not respond when she is spoken to or shaken. This child is unconscious. If the child is lethargic or unconscious, the general danger sign is present.
If any general danger sign is present, you should complete the rest of the assessment quickly, but thoroughly, so there will be no delay in the child's treatment. You will now practice identifying the general danger sign, lethargic or unconscious. You will be shown 4 children. After seeing each child, you should write down whether the child has the general danger sign, lethargic or unconscious. Tick yes or no on the answer sheet. We will tell you our assessment after you have seen all 4 children.
Here is the first child. Would you say this child has the general danger sign, lethargic or unconscious. Write down your assessment now.
Here's the second child. Would you say this child has the general danger sign lethargic or unconscious? Write down your assessment now.
Here is the third child. Would you say this child is lethargic or unconscious? Write down your assessment now.
Here is the fourth child. Would you say this child is lethargic or unconscious? Write down your assessment now.
The first child was wide awake and alert. Therefore, the general danger sign is not present.
This is the second child. She did not respond to any form of stimulation, and we can therefore conclude that the child has the danger sign lethargic or unconscious. A lethargic child is drowsy at all times, even when the child should be awake or alert. Does not look at the mother. Does not interact with the surroundings, and does not watch when someone is talking.
The third child appeared lethargic, but when attempts were made to wake the child, it awoke normally. Some children sleep very soundly, but can be woken. Then they are alert. They do not have the general danger sign, lethargic or unconscious.
We decided that the fourth child was unconscious. The child did not watch the health worker nor stir when attempts were made to wake her. This child did not respond to any form of stimulation. Therefore, we decided the general danger sign is present.
An unconscious child cannot be wakened, cannot swallow, does not respond to stimulation, and does not respond when being spoken to.
After checking for general danger signs, the next step in the assessment is to ask about the first main symptom.
The health worker asks if the child has cough or difficult breathing. If the mother replies yes, assess the child further.
A child with cough may simply have a cold, or may have pneumonia, asthma, or another severe acute respiratory infection. You must be able to identify the few children with pneumonia or other serious infections from the many children with coughs or colds.
If the child has a cough or difficult breathing, ask for how long.
It is important to know how long a child has been coughing, as a cough lasting for more than 21 days may be a sign of tuberculosis, asthma, or whooping cough.
Determining whether a child has fast breathing is an important step in assessing a child with cough. Fast breathing is a sign of pneumonia. When classifying for pneumonia, remember to assess for suspected symptomatic HIV later on.
When a child develops pneumonia, the lungs become stiff, making it more difficult to breathe. The child's breathing rate increases as the child's body tries to make up for lung stiffness and lack of oxygen.
Because children's breathing rate slows down as they get older, the child's age must be taken into consideration when deciding whether fast breathing is present. To decide whether a child has fast breathing, you will count the number of breaths the child takes in 1 minute and compare it with the following cut-off rates.
If the child is aged 2 months up to 12 months, the child has fast breathing if you count 50 breaths or more per minute. If the child is aged 12 months up to 5 years, the child has fast breathing if you count 40 breaths or more per minute. The child who is exactly 12 months old has fast breathing if you counted 40 breaths or more per minute.
We will now watch while the health worker counts the number of breaths that this 7-month-old child takes in 1 minute. Look for the breathing movement anywhere in the child's chest or abdomen. The child should be calm when you watch the child's breathing. If the child starts to cry or becomes upset, ask the mother to calm the child again before counting.
The health worker is now ready to start counting the number of breaths in 1 minute. Practice counting with her. We will tell you when to start and stop counting. Select an area on the child's chest where you can see breathing movement. Prepare to start counting. Start counting now.
Stop counting. How many breaths did you count? The health worker counted 107 breaths per minute. Since the child is 7 months old, he does have fast breathing.
Next, look for chest indrawing.
This child has chest indrawing. Chest indrawing occurs when the effort required to breathe in is much greater than normal. For an accurate assessment of chest indrawing, the child should not be breastfeeding while you observe for indrawing.
To look for chest indrawing, you must know when the child is breathing in. When the child breathes in, the upper chest and abdomen move out. Breathing in, breathing out. Breathing in, breathing out.
This is a healthy child with normal breathing. When the child breathes in, the upper chest and abdomen move out. The lower chest also moves out.
This child has chest indrawing. When the child breathes in, the upper chest and abdomen move out as in the healthy child, but the lower chest moves in. Chest indrawing is this inward movement of the lower chest wall when the child breathes in. Look again. When the child breathes in, the upper chest and abdomen move out, while the lower chest moves in.
Now look for these movements in some children. Look for chest indrawing while the child breathes in. This child has chest indrawing. The lower chest wall goes in when the child breathes in. Chest indrawing is only significant if it is present all the time and definitely visible.
This child is breastfeeding. If you see chest indrawing only when a child is upset or trying to feed, but not when resting peacefully, do not call it chest indrawing. This child only has chest indrawing when feeding. Therefore, we would not call it chest indrawing.
Next, Look and listen for stridor. Stridor is a harsh noise made when the child is breathing in.
If a calm child has stridor, the child is in danger of a life-threatening airway obstruction. Often a child who is not very ill will have stridor only when the child is crying or upset. So be sure to look and listen for stridor only when the child is calm.
Sometimes you can hear a wet noise if the nose is blocked. Clear the nose and then listen again.
You may hear other noises when the child breathes out, such as wheezing. Wheezing is an important sign to identify. Wheezing occurs when the small airways are narrowed, such as in asthma or bronchiolitis. Wheezing must be distinguished from stridor, as these two signs are caused by different illnesses and require different management. This child has wheezing. Look at the chest and listen for the wheezing noise as he breathes out.
That completes the assessment for cough or difficult breathing.
In this module, we will practice counting fast breathing and identifying the presence of chest indrawing, wheezing, and stridor. First, we will practice counting the number of breaths in 1 minute for these two children. In each case, you will be given the age of the child and then asked to count the number of breaths in 1 minute. You should write down the number of breaths you count and then decide whether or not the child has fast breathing.
Here is the first child. Her name is Kanya. She is 3 years old. Prepare to start counting. Start counting now. Stop counting. How many breaths did you count? We counted 42 breaths in 1 minute. Kanya is aged 3 years. The cutoff for fast breathing is 40 breaths or more. Therefore, we decided that Kanya has fast breathing.
Here is the second child. His name is Temba and he is 4 months old. Prepare to start counting. Start counting now. Stop counting. How many breaths did you count? We counted 92 breaths in 1 minute. Temba is age 4 months. The cutoff for fast breathing is 50 breaths or more. Therefore, we decided that Temba has fast breathing.
In this section, we will practice identifying the presence of chest indrawing in 5 children. Here is the first child. Her name is Mary. Does Mary have chest indrawing?
What did you decide? We saw normal breathing. As the child breathed in, the whole chest wall, that is, the upper and lower chest wall and abdomen moved out. Therefore, we decided that there was no chest indrawing.
Here is the second child. Her name is Poppy. Does Poppy have chest indrawing?
What did you decide? At first, it wasn't clear whether this child had chest indrawing or not. We looked at this child again and decided she does have chest indrawing.
Here is the third child. His name is Zweli. Does Zweli have chest indrawing?
What did you decide? We saw indrawing movement in the lower chest wall, while the rest of the chest and abdomen were moving out. Therefore, we decided that Zweli does have chest indrawing.
Here is the fourth child. His name is Thabo. Does Thabo have chest indrawing?
What did you decide? We saw normal breathing. As the child breathed in, the whole chest wall and abdomen moved out. Therefore, we decided there was no chest indrawing.
Here is the fifth child. Her name is Anna. Does Anna have chest indrawing?
What did you decide?
We did not see consistent indrawing movement in the lower chest wall and abdomen all the time. Therefore, reposition the child and assess the child again to decide if chest indrawing is present or not. We looked at this child again and decided she does have chest indrawing.
In this section, we will also practice identifying those children with stridor or wheezing. We will be assessing 4 children.
Here is the first child. His name is Sakile. Look and listen to his breathing. Does Sakile have stridor or wheezing?
What did you decide?
We heard a harsh noise when Sakile was breathing in. Therefore, we decided that Sakile does have stridor. Listen again.
Here is the second child. Her name is Lerato. Look and listen to her breathing. Does Lerato have stridor or wheezing? What did you decide? We heard a grunting noise when Lerato was breathing out and established that the child was having difficulty in breathing. We therefore decided that Lerato does not have stridor or wheezing, but difficult breathing.
Here's the third child. Her name is Tebogo. Look and listen to her breathing. Does Tebogo have stridor or wheezing? What did you decide? We heard a wet noise when Tebogo was breathing in and out. Therefore, we decided that she did not have stridor or wheezing, but a blocked nose.
Here is the fourth child. His name is Mandla. Look and listen to his breathing. Does Mandla have stridor or wheezing? What did you decide? He had a wheezing sound when breathing out. Therefore, we decided that Mandla did not have stridor. Stridor is a harsh sound when breathing in. This child has a wheeze when breathing out. Listen again.
That completes the exercises for assessing breathing rate, chest indrawing, wheezing and stridor.
You will now be given the opportunity to practice what you have learned so far with an actual case study. Mary has been brought to the clinic by her mother. She is 7 months old. She weighs 8 kilograms and her temperature is 38.5 degrees. Her mother says she has been coughing for 2 weeks. First, check the child for general danger signs. The mother says that Mary is able to drink, is not vomiting, and has not had convulsions. Look at her to see if she is lethargic or unconscious. Write down your assessment.
Does Mary have any of the general danger signs? Now assess Mary for the main symptom of cough or difficult breathing. Does the child have cough or difficult breathing? Mary does have a cough, so ask the mother for how long she has been coughing.
She has been coughing for 2 weeks, and the cough is getting worse. Count the breaths Mary takes in 1 minute. Prepare to start counting. Start counting now.
Stop counting. Write down the number of breaths you counted and decide whether Mary has fast breathing.
Now look for chest indrawing. Write down whether chest indrawing is present.